Buongiorno a tutte e a tutti anche da parte mia. I will speak in Italian. I joke. I will speak in my English, that is quite close to, to Italian. I joke. Welcome to everybody. It's a big honor, but it's also a little bit a challenge to present and to moderate this session with Professor Martin McKee, and I will keep it extremely short as an introduction. Just to say that, as you can see on the Lugano Summer School website or elsewhere, Professor McKee has, a long history in public health in different roles. I would say both in research, but also in policy advising, of course, in education. Basically, medical student, so physician as original training, you will see in internal medicine. After that, he specialized in public health and is based basically in London at the London School of Hygiene and Tropical Medicine. But he was also very much involved in other initiatives. I remember very well because I'm attending every year the meetings of the European Observatory, in particular of the health, a network of people looking at the health systems, the European Observatory on health systems, where Martin McKee works till now. He was one of the founders there, and also in terms of European Public Health Association in the past, several journals, above all the journal of the European Public Health Association that is called the European Journal of Public Health. So today we talk about health systems. Martin McKee has always looked very closely to health systems, so organization, provision of services. I remember transition countries in Eastern Europe several years ago. I remember very often he took position on UK NHS reforms and more recently about COVID and the resilience of the health systems. So I'm eager to listen to his presentation. Thank you again, and I leave the floor to Professor Martin McKee.
Well, buongiorno a tutti. No parlerò in italiano. Bonjour tout le monde. Guten Morgen allerseits. Good morning, everyone, and thank you for the invitation to be here. And yeah, so there we are. Right, so as I say, the title is The Challenges and Opportunities Facing Health Systems, and this is an enormous topic. I could talk for hours, but of course I'm not, because you've got a reception to go to at 6:30 this evening, and we need to be finished before that. So the obvious thing to do is to take what other people have written about this. And you can do one of two things. You can put it into ChatGPT, or you can put it into a word cloud. So I put it into a word cloud, and I got all of these words about costs and chronic and patient and healthcare and so on. Didn't really help very much. So I've got to try to organize this in some way that makes sense to you. Typically, people giving this sort of talk about a couple of things. The growth of multimorbidity. Sadly, as we get older, we accumulate chronic conditions. Once, people with these chronic conditions would just have died. I can remember when I was a junior doctor in Belfast, people with malignant hypertension, hypertensive crises. In some of your countries, you will still be seeing things like this. But we can treat hypertension, we can treat many of these chronic diseases, like chronic airways disease, new treatments for diabetes all the time, and so on and so forth. So people are living with these conditions. So that's one thing we could talk about. And then another thing that we often talk about is the growth of precision medicine, targeting drugs to individual molecular receptors. the growth of our understanding of genomics and so on. So I could talk about that. And then I could talk about the multidisciplinary team. And this is a picture from the Scottish government. And you can see that there are lots of people involved in the I thought from the earlier noise I thought Switzerland was a peaceful country that hasn't been to war for, what, 600-700 years, and I heard the noises and I thought, my God, the artillery are opening up from across the lake. So these are some of the people that are involved in the coordination. So that's another thing I could talk about. But that's all far too complicated for 30 minutes. So what I'm going to suggest is that when we look at the challenges and opportunities facing health systems, it's really much easier. Our task is to get the right health workers with the right tools and the right skills in the right place at the right time. It's as easy as that. Or, put another way, it's as difficult as that. So let's go through those bit by bit. Who are the right health workers? Well, obviously it's changing. And we could talk about task shifting. And we know that with all sorts of developments, we're seeing that things that were once done by doctors are now being done by other people. When I was a house officer, one of my roles was to go and take bloods of patients every morning. My counterparts now certainly don't do that. There's lots, but what they do, which I didn't have to do, was to enter data onto computers after seeing every patient. So things have changed in lots of ways. So we've got groups like a shift of roles and responsibilities between doctors, nurses, physiotherapists, occupational therapists, and others, pharmacists. But it's not just that. Because nowadays, as a patient with a chronic condition, you will buy an automatic sphygmomanometer from the pharmacist or have a wearable real-time glucose monitoring or a handheld ECG or a watch which tells you if you've got an arrhythmia, and so on and so forth. So patients and carers are taking much more responsibility, and machines are taking on a much greater role. So when we talk about the right workers, it's not just the health workers, but it's the carers and the patients working in partnership and working with machines that are changing the role of the health workers, but also changing the role of the carers and of the patients. So let's just put that to one side. That's one thing that is changing. The other thing, which is a problem in so many countries, the high-income countries, and I speak from personal experience, we're getting older. Well, not you, but we're all getting older. But I, in particular, am getting a lot older and infirm and aged and losing my cognitive abilities and my manual abilities. And if I come back next year, I'll barely be able to climb up on this stage. But that is a reality. You really do not want a surgeon doing microvascular operations when they're my age. You just lose the skills. And of course, people are leaving the workforce. Now, one of the things I'm not going to talk about here is the global shortage of health workers, because I sometimes think we've got that wrong. I work in a number of African countries. I know many of you are from African countries. Who's from Nigeria? Anybody? There are people from Nigeria. So, I work with colleagues in Kano and Enugu. And we're not sure that there is such a shortage. There are a lot of health workers who are working as volunteers in health facilities and districts. There are a lot of health workers who are not working as health workers. So it's more complicated than that. So we can talk about that in Q&A, but let's leave that for to one side. But there is really a problem with aging health workers. And the other thing that there's a problem with is burnout. People are getting exhausted. Health workers are getting fed up. They're feeling underpaid, unloved, badly treated, and particularly during the pandemic, they've just had enough. And they're leaving, to say nothing of the ones that got long COVID or died. So that's my issue about the challenges for health workers in the future. Basically, what do we do to retain health workers in the workforce, either by paying them properly in many low-income countries, so they actually want to work in the health system and not somewhere else, and some will migrate, of course. But how do we also stop them from getting burnt out So those are the issues about the right workers and doing the right things. Recognizing patients and carers are important too. And then we come to the right skills, and what do we need? So on next Saturday, I will be in Basel talking to the heads of European medical schools, talking about selection of medical students. Now, when I started doing medicine in 1974, in fact, next month we have our 45th anniversary reunion from my medical school, those of us who are still around, and I think I'm about the only one still working. But the skills that we needed then were very different from what we need now. So we now need people with technological proficiency in digital health records, telemedicine, medical devices, people who can work together as teams. I don't know what it was like where you trained, but I know that there were a number of surgeons whose idea of working in a team was basically giving orders to others. The idea that they would ever discuss treatment with the patient or their colleagues was unimaginable. Patient-centered care, empathy and compassion, cultural competence, understanding that if you're treating patients with different religions or from different backgrounds, they may have different understandings and expectations. The ability to interpret data, to apply the rapidly increasing amount of research and evidence, the roles that one plays in chronic disease management, leadership, which I think you'll be talking about more, emergency and crisis response, which you're certainly going to be talking about more. How do you get people who can step up in a pandemic or a natural disaster or a human-made disaster? Ethical and legal knowledge, advanced clinical skills, precision medicine we have talked about, mental health, including caring for oneself. So there's a whole range of skills that we often underestimate. It is more than anatomy, physiology, biochemistry, pharmacology, and pathology. Much more. A warning. Now, the United Kingdom is a great country. It is a great country because it is forever making mistakes that other people can learn from. And this is our contribution to the world. And our current mistake that we are making that you can learn from is to dumb down medicine. The British government, the last British government, sort of gave up on trying to recruit and retain doctors because it treated them so terribly. So what it decided to do was to bring in a new type of worker who would have, hopefully, a science degree, but perhaps in the humanities or the arts. Nothing wrong with that, but it's very different from doing anatomy, physiology, and biochemistry. And they would have 2 years training, and these are now being employed on rotas with junior doctors. Yes, you look in incredulity. You think, how can a country do such a thing? Well, it can. And well, anyway, you can see the Daily Mail headline. This is proving to be a disaster. It costs much more because the doctors have to supervise them. Then there's a growing professional and public backlash because patients are dying. An increasing number of patients are being misdiagnosed and dying. But it's an ideological solution, and in a recent paper I published, you can look at it online, called The Sovietization of British Medicine. It replicates what was done in the Soviet Union by Stalin in the 1920s of dumbing down medicine and bringing in para-health workers. So just a warning, things that seem like a good idea in theory may not be in practice. Now we need to get people in the right place, and how do we do that? Where do we put them? There is a philosophy in much of health systems and services research that hospitals are like dinosaurs. They're dying out. But actually, they have managed to survive much longer than anybody thought. The question that we face in health systems going forward, and it's not an easy one, is how we balance concentration of scarce resources with easy access to care. So centralizing specialized healthcare services can give you more efficient healthcare and use of scarce resources. It gives you economies of scale, it reduces duplication and so on. But, and you know in many of your own countries where development agencies came in and built a big teaching hospital in the capital, and then that took away all the resources for the rest of the country. So you've got to get a balance. How do you get that balance between specialist services and access? And it's not an easy one. We've written books on it. there is a challenge there. And then the issue of coordination of care and continuity of care. Centralized care can help coordinate care because you've got all the people together. You can go down the corridor and talk to the therapist or to somebody with specialized expertise. And that may improve the way in which the patient is treated. But on the other hand, if people are living far away, it may be much more difficult. So it's not an easy one. This is a balance. So all I'm saying here is people who say we should get rid of all the hospitals or we should put everything in the hospitals, neither is right. It's a complex situation. And that takes us to the question of what a hospital does, because hospitals do lots of things. Of course, they diagnose patients, but patients who often don't know what is wrong with them until after they've left. It's not like a production line in a factory where you're making nuts and bolts or plastic toys or something like that. When people come through the door, you may know what's wrong with them. You know, somebody that comes in with an arrow shot through their neck, it's pretty obvious, except you don't know what is actually hit inside. It's amazing, because I've seen people shot in the neck, how bullets can actually pass through, but that's another question. They will not know what they have often. You will not know what they have. Now, sometimes you can just put them in a pathway if they've got a breast lump or bleeding in the urine or something like that, bleeding in the feces, you know, then you put them in a pathway. And most of them will have a limited number of conditions, but some will not. So it's complicated. You want to treat patients who may have multiple disorders. You want to monitor people who have got specialist needs, which cannot be looked after in primary care, particularly rare genetic conditions and so on. Hospitals are training facilities for health professionals. They play a very important role there. Undergraduate, continuing education, and they are settings for research. But above all, a hospital is a key part of regional infrastructure. And we see that in places like Maastricht, for example, where the hospital and the teaching hospital, or Kuopio in Finland or somewhere like that, where there was an investment in the health research complex to replace the deindustrialization. And similarly, in a region that is declining with deindustrialization or population movement, closing the hospital can be the final straw, the final damage to that community, and that accelerates the people leaving those rural areas because they've lost their schools, their hospitals, and so on. So you've got to think about that too. Hospitals are fiscal multipliers. Money spent on them, providing they use the money properly, can support local industry, local employment, all sorts of other things. So just be aware of that. So we've talked about in the right place. What about at the right time? Well, think about what it is like now when somebody is having immunotherapy for melanoma or some of the more complex cancers. In the old days, it was really easy. If somebody had a cancer, you cut it out, or you fried it with radiotherapy, or you poisoned it with chemotherapy. Much of the chemotherapy was derived from mustards and things like that, basically chemical weapons. And that was relatively straightforward. Not that straightforward because, remember, even 10, 20 years ago, very little radiotherapy capacity in much of Africa, for example. But in theory, it was easy. But now you need to get the tumor out. You need to look at the receptors on the cells. You need to understand the genetics of it. You need to understand how the genetics are changing, because just as you get antimicrobial resistance, you get resistance to chemotherapy, targeted chemotherapy. So this is really getting very challenging. So what we did in a paper, and you won't read this, I'm simply using it to show the complexity. We worked out what is needed to provide a cancer service in industrialized countries. And this is what it looks like. And the bits in the red rectangle are those bits in the hospital. It's not easy. There are a lot of things that need to be brought together. Now, getting people in the right place at the right time is challenging. I guess many of you flew here. You came through airports, not right? How many people came on a plane to get here? Okay, when you got to the airport, what did you do? You went maybe to the check-in, maybe you checked in online, and then you went through security and immigration or emigration, and you went to the gate. You were moving in a straight line. But in a hospital, people don't move in straight lines. They move in every direction. And many of them, I mean, in an airport, some people need wheelchairs, and we know that that often doesn't work. But in a hospital, a lot more do, or maybe in a trolley. They may get lost. We've had examples in the UK of people being found in toilets 3 days after they died. I don't think we're unique in that. And so you have all of this chaos that is going on in a hospital, and you've got to have somebody trying to manage it. Now, if we had the people with the expertise in air traffic control, highly paid, who make sure that your planes don't crash over Europe, hopefully, or wherever, then it might help, but we don't have that. So you can see how difficult it is to get everybody in the right place at the right time. And then if life wasn't complicated enough, so I started off with a very simple proposition. Right mix of people with the right skills, the right tools, in the right place at the right time. Easy, but not so easy. But let's start with the easy bit. Then we have the risks of, well, one of the things I did 2 years ago was write the report for the Pan-European Commission on Health and Sustainable Development, chaired by my colleague Mario Monti, a former Italian Prime Minister. And we listed a whole series of things here. So we've got climate change, we've got the risks from space. I know a number of you are from Ukraine, a country I know very well. We have antimicrobial resistance. And then, of course, we had the pandemic. And that threw everything into disarray. Are we any better prepared? Well, let me argue why I don't think we are. I'm going to suggest to you that a country going through a pandemic or countries going through a pandemic are like a fleet of ships going through a storm. So what can we learn from all of that? Well, a quick plug, you've already had the mention of the European Observatory. I'll just say we produce a huge amount of material which can be useful. Our book on resilience, and then we have another handbook on strengthening health systems, written by another McKee, not me, but my youngest daughter, who will be coming this evening. Nepotism, but she normally works for other people. But I'm going to argue that what we have, if we take this analogy, is we need a captain on the ship. We need somebody who's actually in charge. Every country needs somebody who is in charge, who knows what they're doing. In a storm, they understand the laws of physics. They know if the wind blows in one way, they must set the sails to get the ship to go in a particular way. You do not want a captain who thinks that viruses can be killed by shining ultraviolet light into bodily orifices or by drinking bleach. You do not want that. You want that captain, not thinking of any country in particular, you do not want, I'm thinking of another English-speaking country, a captain who is not on the deck of the ship because he's sorting out his very messy divorce, the UK, and who missed all the original meetings. So you want a captain who knows what they're doing. You want a crew on the ship who are there. You do not, the middle of a storm is not a good time to go out to an employment agency and say, we want to recruit 20 sailors. You don't send a message to the shore to say, can you find us 20 sailors? Because we need them now. Yes, but how do we get them to you in the storm? You want ships that are well built, strong, and have safety nets, including social safety nets. You do not want people falling through the holes in the decks. You do not want people falling through the holes in the welfare system. You do not want people in precarious jobs who, when there's a lockdown, have no money. You need strong structures in place. You need a way of communicating with other countries. And if you have just, for the sake of example, sorry, these examples are European, if you've just, for the sake of argument, decided that you want to leave a major bloc of 27 neighbouring countries with which you were talking very regularly and cut yourself off from them so you have no means of communicating, that's not a good idea either. Sorry for the European analogies. You want surveillance systems, you want a lookout, and you want the right chart. If you're in the storm in the Indian Ocean, having a chart of the Atlantic Ocean is not much good. If your pandemic is coronavirus, having a chart which says influenza is not much good. So I'm arguing that we need a major transformation. And how are we going to do that? Well, I'm going to argue that we need a systems approach. I'm a great believer in soft systems. Essentially, healthcare is delivered in complex adaptive systems. Sorry about this. I'm trying to look at the screen at the same time. And it's, any complex adaptive systems, soft systems are different from hard systems. A hard system is like taking all the bits of a bicycle and bolting them together. You know that if you've got all the right bits and bolted together and you do it properly, the bicycle can be ridden. A soft system, when you bring all the bits together, they interact with each other. People don't do what you think they will do. In your bicycle, the chain has a very simple task. It has to go round and round and turn the wheels. In a soft system, the health workers don't necessarily know that they're meant to go round and do a certain thing. So it's more complicated. And the challenge is that you need to be able to, you need to recognize that when you make changes to one subsystem, it will have implications for others. You need to be aware of the importance of starting conditions. If you do not have a functioning banking system, don't try to set up a complex health insurance system. If you don't have an accurate population register, be careful, you will be limited in what you can do. So the starting conditions are important. You're going to be making a whole series of changes. And this is an example of a paper that we did, which is the one I'll be talking about on Saturday in Basel, where the British government has decided it wants to expand medical school numbers. But it hadn't done this sort of analysis. And the plan is going nowhere because it hadn't thought through, are there enough people to build the new lecture theatres? Well, the answer in the UK is no, because all the Polish builders that came in when we were a member of the EU have left. That's one problem, but I could go on and on. So there are all sorts of challenges, and we talk about the changes you need to make in each system, the people who must do it, the people who will benefit from it. And within a system, it's not just the patients who benefit, the staff benefit by being paid, the pharmaceutical manufacturers benefit by being paid, the people who build hospitals benefit because they're employed to build the hospitals. Lots of people in different subsystems will be different beneficiaries. And who can make it all happen? And that's often the most difficult. Ministers are often saying, I'm the minister. Why can I not get anything done? There's a famous quote from John F. Kennedy, who said, after he became president, he said, when I was young, I thought that if I could get into Congress, into the House of Representatives, that would be the power, that would be where the power was, and I could do something about it. So I became a congressman, and I had no power. And then I thought, well, maybe I can go to the Senate, and there I'll have power. And I got there, and I had no power. And then I thought, I'll go for president, and I'll get there, and I'll have power. And he said, here I am, and I've got no power. So finding out who can actually make things work is really challenging. But none of this will work without one particular thing. I'm going to have to go through this a bit more quickly. And that is trust. We really need to build trust, and we have a book coming out on that shortly. We have a policy brief from a conference we ran in Estonia in December. We need patients to trust the system. We need health workers to trust the system so they don't emigrate or retire early. And we need politicians to trust the system so they believe that if they put money into it, something good will happen. And then I just want to use an example of how complicated everything really is. We may not be able to do everything that we can in theory do, at least not the way we can envisage it. I talked about precision medicine. One of the great hopes that we have is radioligand therapy. If we can take either antibodies or cells that bind to receptors in cancer cells, and we can put them into people, and so the molecules bind to the cancer cells, and if we have attached to those molecules a radioactive substance, then we can kill the cancer cells. It's not like zapping somebody with radiation. It's being very, very precisely targeted. Now, you all know, I guess, that what we want are particles that don't travel very far through tissue. We don't want to kill all the cells around them, so we want alpha particle emitters. And we don't want them to stay around for a long time. So we want a radioactive isotope, which is an alpha emitter, which is short-lived. Easy, you think. All of this investment, we've got nuclear reactors, we can produce anything we want, you would think. Actinium-225 is really good for this. It emits alpha particles, half-life 9.9 days. Where do you get it? It doesn't occur naturally. Well, there is a bit on the market from Russia, but you'll know the issue around sanctions and the challenges there. The other place you get it is from the reactors of nuclear submarines, and there have been lots of negotiations to get them from there. But the United States Navy, the British Navy, French Navy, and others have not been, they've got all sorts of issues there about providing it. The current supply is very small, but even if you were to treat everybody, it would not be enough to justify building a reactor that would produce this, because you'd just be producing far too much. It's a real challenge. So you can see that we may know what to do, but there are other factors which make it much more complicated. Now, one way we can go forward is a chatbot. The robot will see you now. Because of time, I won't go into this too far, but I'll just simply say that the hype really exceeds the reality. Now, I'm sure that many of you use AI all the time. Anytime, I don't know if you're like our house, we use Alexa to switch the lights on, to switch the heating on or off, and all sorts of other things, play the radio in the morning, Siri, all the other assistants on voice recognition. If you may write using voice recognition, you will be using chatbots when you're engaging with apps and with websites and so on. But we're nowhere near the sort of vision of the AI taking over the world and having emotional intelligence. That doesn't mean that there aren't ways and things you can do. Now, I know you're talking a lot about emergencies, and I'll just say very briefly, this is a list of things that we've come up with about the way that AI might be used in emergencies that we'll finish very shortly. But they go through disease surveillance and pandemic modeling and drug discovery, making sure that personal protective equipment gets to the right place at the right time, public health messaging by understanding how people understand messages, and robots and all sorts of things like that. Robots really important because you don't want people driving around the countryside delivering things in a pandemic. If you can get driverless lorries or something like that, then that reduces the risk of infection. Understanding symptom complexes, looking at so many different things that are listed on there. But as I've said, the real problem is that when you read the literature as we have done, and we will be publishing a policy brief on this soon, much of it doesn't go on beyond proof of concept. And we have many problems around the use, having all of this personal data that can be hacked into, vulnerable to cyber attacks, which we saw during the pandemic with cyber attacks. When we're using it in clinical settings, we need to get the right amount of trust. Health workers need to trust the algorithms enough to use it, but not so much that they do not challenge it when they know it is wrong, something we're doing a lot of work on that. And then we have the real issue, this is my last slide, autophagy, because large language models and so on are learning from all of the material out on the internet that humans have produced. The problem is that increasingly the material on the internet was not produced by humans. It was produced by AI in itself. And the difficulty there is if that AI has made a mistake, that mistake will then be replicated. And it is a bit like the system eating its children. Now, there are other historic examples of where something seemed very straightforward, and then once it is used, it has built-in obsolescence. Geiger counters. Geiger counters, detectors for radiation in metal cases. And building the first metal cases in the 1890s, from Marie Curie onwards up to the 1950s, was straightforward. You got a lump of metal and you made a case. But then after the 1950s, the metal you were getting was contaminated by the fallout from atmospheric nuclear testing. So where did you get your metal from? And that's why people spent so much money digging up the ruins of Second World War battleships and things like that, steel that was produced before atmospheric testing. But we can't do all that forever. So this is a great idea, but we don't know where it's going. And at that, I've talked enough, but we did start a little bit late, and time for questions.